It's my pleasure today I get to introduce Dr. Breann Kelley. She is a board-certified internal medicine physician. She specializes using non-surgical weight loss methods to treat obesity, overweight, and weight-related health conditions. In 2016, Dr. Kelley received the honor of becoming an American Board of Obesity Medicine diplomat. And more recently, she was nominated this year for the Pitch Best of Kansas City Weight Loss Clinic and for Townsend. Dr. Kelley has a really unique ability to meet patients where they're at on their journey and develop an effective weight loss plan for long-term success, which is what we're all looking for. Outside of work, she really enjoys spending time with her family. She loves reading and traveling. Dr. Kelley is an avid runner. She's completed dozens of marathons, 3 full marathons, and 1 ultra marathon. So please join me in welcoming Dr. Breann Kelley of the Total Weight Loss Center. I am not quite as loud as Jackie or as extroverted. So I'll take the mask off so you can see my face. More than 6 feet from all of you. And fully vaccinated. So I am Breann Kelley. I am board certified in internal medicine, so adults, and I am also boarded by the American Board of Obesity Medicine. I do weight management full time at the Total Weight Loss Center. So first thing I want to talk about is the criteria for excess body fat. In the upper right corner, you'll see the traditional BMI that we're all familiar with, you know, underweight, normal weight, that sort of stuff. BMI is the least accurate measure of excess body fat. Waist circumference and body fat percentage are much more accurate. But BMI is what, you know, insurance companies use, and it's easy for us. We've got your height, we've got your weight, the computer system calculates BMI for us. The other thing I will point out on that chart is there is no such thing as morbid obesity. That is an offensive term. It's not correct. It makes me angry. It's not up there. It's class 3 obesity. Let's see here. This is why we care. And this is not an all-inclusive list. These are conditions related with excess body fat. And like I said, not an all-inclusive list. There's a lot of things that are not surprises. Sleep apnea, heart disease, stroke, diabetes. There's at least 13 different types of cancer that risk is increased as we increase body fat, especially visceral fat. And the smaller one did not transfer very well, but the long and the short of it is adults in the state of Missouri, there's roughly 32% of us struggle with obesity. So if you look at all of these health problems, it's a big problem. Medical weight loss, what I do. So the simple way to define it is it's non-surgical. I work with 2 surgeons. I don't do what they do. I do these other 4 things. So these are the pillars: nutrition, exercise or activity, behavior modification, and medication. I'm going to touch on all of those a little bit. But first, I want to talk about one of the questions I get most often: how much do I need to lose, or how much do people need to lose to improve health? 5% weight loss is enough to start seeing improvement in blood pressure, blood sugar, and cholesterol. That is medically significant weight loss. At 10% weight loss, we see improvement in just about every weight-related health condition: sleep apnea, acid reflux, fatty liver, stress urinary incontinence, several types of cancer. So you name it, at 10%, risk improves. So the long and the short of it is 5 to 10% weight loss will drastically improve your health, especially if you can maintain that long term. So for a 200-pound person, you know, that's 10 to 20 pounds. It's not nearly as much as you probably think. This is our friendly obesity treatment pyramid. So this is where we start various treatments and how much weight loss we can expect with them. So with medications, weight loss medications, we're typically starting those with a BMI over 30 or 27 with risk factors. So blood pressure, cholesterol, diabetes, that sort of stuff. Surgery, looking at BMI over 40 or 35 with those risk factors. These are additive.
So I use the bottom three, basically. I combine pharmacotherapy with dietary changes and lifestyle modification, and I'm pretty reliably getting 10, 20% off of people. Young, healthy people, I've even pushed up to 30% with the combination. So another pet peeve of mine, eat less, exercise more. It's garbage advice. It's based on the theory that all calories are equal, and they're not. 100 calories of M&Ms and 100 calories of spinach do wickedly different things when they get inside of us, right? Like otherwise our moms wouldn't have tried to feed us vegetables and keep us out of candy. We know they're different, okay? And we'll talk on exercise in a minute, but it's less helpful for weight loss than you think until you get to the extremes. What does regulate weight? There's 30 hormones between your brain and your gut that regulate weight and appetite. And 26 of them, grossly oversimplified, 26 of them tell you eat more, store fat, and 4 of them tell you eat less, burn fat. Most of our hormones, most of the time, are trying to get us to eat more and store more fat because we're designed to survive famine. We're supposed to be hunters and gatherers, up and active, eating plants and animals. We are not supposed to be sitting in front of a computer all day, like me, or eating the standard American diet. So that's problem number one. We're designed to survive famine. There is no famine in the Midwest. It is feast of plenty. And we know that people that struggle with weight have higher levels of hunger hormones, lower levels of full hormones. We are literally hungrier. We also have different bacteria in our gut. And this is the new area of research, which is just fascinating. These gut bacteria changes can affect our cravings, behaviors, including activity level, all sorts of things. Environment can be an issue. If you live in an area where you don't have access to fresh foods, what we call a food desert, it's all fast food around you, not grocery stores, that sort of stuff, or don't have a place to safely exercise, that can be a problem. And then genetics and epigenetics, or how I jokingly refer to it is famine proof is passed down. So if your ancestors survived famine, they made you better able to survive famine. This is really stolen from like online Webster's. This is just the definition of diet, multiple definitions. What I'm really talking about is all of them, but mostly 3 and 4. The special kind of food we prescribe for a special reason, and trying to eat and drink sparingly to reduce weight. And there will be more on nutrition later on October 14th and October 26th. 2 of my 4 favorite dietitians will be presenting. Are you next? Jackie's next. But I am a big fan of low carb diets. And one of the reasons is insulin resistance, and I'll talk about that in a minute. But I am a big fan of low carb diets also because I think science is awesome. And if you look at the science of carb diets, they basically drug low fat and beat them up. I mean, if this was a drug, it would be FDA approved. What's that? Randomized controlled trial. So insulin resistance, I'm going to talk about what insulin resistance is. Basically, it's your muscle cells not listening to insulin. When we eat something, our blood sugar rises, our pancreas sends insulin to deal with it, pull it out of the bloodstream, blood sugar comes back to normal. Insulin takes that sugar, muscle cells, fat cells. Muscle cells burn it for energy, fat cells store it for fat. Every time we eat, our insulin rises, we store fat. The more it rises, the more fat we store. It's why prednisone causes weight gain. In insulin resistance, our muscle cells are acting like toddlers. They're not listening to that insulin. They're refusing that sugar. The problem is fat cells never become insulin resistant, so they pick up the extra. And with that, your pancreas will pump out more insulin to try and yell at your muscle cells. So now there's more insulin, more fat stored, okay? Other reason I love low carb diets. Insulin resistance can be normal. Puberty, pregnancy, acute illness, aging. So you've got a picture of my 2 pubescent boys there. Pregnancy, it's why we do glucose tolerance tests in pregnancy. And when gestational diabetes is that normal insulin resistance carried a little too far. acute illness. That's why sometimes we have to use sliding scale insulin in the hospital in people who are not diabetic. And then aging, even, really thin people, sometimes 70s, 80s, 90s develop type 2 diabetes. And then the abnormal stuff is the stuff I really worry about. And all of these things, stress, sleep deprivation, prolonged sitting, excessive calorie intake, visceral fat, this is all additive over time. One night bad sleep isn't gonna make or break you. This is another way of looking at what goes into insulin resistance. So, genetics, activity, medications. Yes, medications can contribute to it. Sleep disruption, sleep disorders, routine aging, and then the things that can result. And I don't think diabetes is a surprise to anyone. That's kind of the last stop on the insulin resistant train tracks. But fatty liver, cholesterol issues, polycystic ovaries, those things can be seen as well. Here's a quick way, if you know what your cholesterol is or what your cholesterol panel looks like, here's a quick way to know if you might have insulin resistance. So basically, if your fasting triglycerides are over 130, or if your triglyceride to HDL ratio is elevated. So for example, triglycerides of 150, HDL of 50, that's a ratio of 3, 150 divided by 50. So in women, if it's more than 2.5, that's where we see insulin resistance. In men, it's more than 3.5. And then the HOMA-IR, or homeostatic model assessment for insulin resistance, is it's a score, it's a calculation we use, fasting insulin and fasting glucose levels, and scores over 2 are consistent with insulin resistance. This one helps us figure out what I call pre-diabetes. So by the time you develop pre-diabetes, your blood sugars are elevated. You have insulin resistance for years before you develop pre-diabetes, and that's what I call pre-diabetes. And the HOMA-IR can help us find that. Moving into exercise. Exercise isn't super helpful with weight loss until we get to the extremes. It is helpful for general health and maintenance. And so the general recommendations are 150 minutes per week for general health. So 30 minutes, 5 times a week. For weight loss, you're looking at least 300 minutes per week. So that's an hour, 5 times a week. And if you're a postmenopausal woman, it's probably 7 hours. Sorry. Yeah. Good news, when the next great famine comes, you're going to make it. But yeah, postmenopausal women are a particularly famine-proof group. The other thing is it takes less exercise than people think to start seeing health benefits. A 10-minute walk outside, and outside is really good for us. So 10-minute walk outside, you'll start to see a boost in serotonin, which is happy brain chemical. You feel good, you do good. You feel bad, you do bad. So starting serotonin level can be super. The other thing is putting that 10-minute walk after your largest day of the meal, or largest meal of the day, can be super helpful as well, because then more of that insulin and sugar is getting used by muscles instead of fat cells. Behavior modification, more on this with Dr. Harris in a couple of weeks. This is my youngest after I made her do the Z-Run. Sleep. So these are the things I focus on a lot. Sleep. Adult humans need 7 to 8 hours of sleep. If you don't get enough, it increases your hunger hormones, it decreases your full hormones. You will literally be hungrier. Those hormones are not interested in salmon and broccoli. They want M&Ms and chips and, all of the things that we know we should probably steer clear of. Treating sleep apnea helps with weight loss. It gets us better quality sleep, so it helps start getting those hormones back where they need to be. It also reduces risk of heart failure and stroke and major badness. Sleep hygiene is something I'll talk about. So, same bedtime, same wake time, staying away from backlit screens, TVs, phones, e-readers before bed within a couple hours. Same bedtime routine in the same order. Ideally, keeping the TV out of the bedroom. Stress management, therapy, if you haven't done it, you should. I recommend it for everybody. Yoga is wonderful because it hits 2 things. You get the exercise component and you get the mental health benefits. So I love yoga. And there's online ones too that you can find. Meditation, I will often tell people to do one of the apps for your phone. So like Insight Timer is one that's free. Calm is one that has, I think, a fee with it, but it's guided meditation. So it walks you through it. Anybody can do it. Planning includes meal planning, but it also includes what I call pessimistic optimism. So you're optimistic, you know you can do it, but you also live in the real world and you know that there are challenges. So planning for those challenges. If you drive past a donut place you have hard time saying no to, drive a different way to work. Come up with strategies for dealing with the food pushers in your life. And Jackie knows my strategy. I go for the gross fat factor. I tell people it causes me incredible intestinal distress and they back off real quick. So, I mean, yeah, come up with those strategies. And then daily habits, this is from the National Weight Control Registry. It's a study out of the University of Colorado, and they are looking at people that have lost significant amounts of weight and have kept it off for a significant amount of time. So what we know these people are doing is they're eating breakfast every day, a high protein breakfast. They're checking their weight frequently, so at least a couple of times a week. And if it starts to get off track, they're taking care of it sooner rather than later. They're tracking their nutrition, whether it's with a smart app or pen and paper, and they're exercising pretty regularly. Most of them are getting at least 150 minutes of exercise a week. Medications. So what I do with medications, I change medications that are causing weight gain to medications that are weight neutral or can help with weight loss. Or if I can't do that, I can minimize the amounts of them, the types of them, the doses of them. And I also add medications that promote weight loss. This is not an inclusive list, but here is some examples of medications that can contribute to weight gain. And people who are prone to weight gain will gain even more weight with these medications than people who are, you know, quote unquote, naturally thin. They may not be as effective. So there's medications for depression, diabetes, high blood pressure, seizures, pain, allergy, obviously prednisone, but even things like tamoxifen, which we use after breast cancer, and Depo-Provera, which we use for birth control or, you know, heavy periods. It's not just phentermine. So many times I ask people if they're interested in medications for weight loss, and they're like, oh, I can't take phentermine. I have a lot more options than that. It's the oldest, it's been around since 1959, but there's more, I promise. The other thing is, we talked about how almost a third of our state struggles with obesity, and 5 to 10% weight loss improves weight-related conditions. And if you remember that pyramid, we're getting there and past there with medications. Only 2% of people who are candidates for anti-obesity medication are receiving a prescription. This is a grossly undertreated problem, and you're not the audience. I should probably be talking to a room full of primary care physicians, but we're not treating this adequately. These are some of the medications we use for weight loss. On the left-hand column, there's your phentermine and 3 of its cousins. They're approved for short-term use. In the middle column, we have ones that are approved for weight loss and weight maintenance. And on the right-hand column, we have medications that are not approved for weight loss. They are FDA-approved drugs. They are FDA-approved for other indications, but they do cause weight loss, and so we use them for that purpose. It can help with weight loss. So I'm going to go into these a little more detail. So the stimulants, phentermine's been around since 1959. It's the oldest weight loss medication. It's cheap. It's the most commonly prescribed weight loss medication. Its cousins, phendimetrazine, diethylpropion, and bensphetamine, work similarly. They're stimulants. They decrease appetite. They increase resting heart rate by increasing heart rate, blood pressure, core body temperature. They're approved for short-term use, typically a few months, although there's not exact guidance on that. And again, BMI 30 or higher or 27 with risk factors. Obviously don't want to use it in people who have uncontrolled high blood pressure, heart disease, pregnancy, that sort of stuff. Orlistat is over the counter as Ally. It's a prescription as Xenical. It is approved actually for overweight and obesity, so BMI of 25 or higher. It is approved for weight loss and weight maintenance. It blocks absorption of some dietary fat. so it can cause a laxative type effect. I don't use it unless people are constipated. Take it as a laxative, bonus weight loss. I actually had a patient recently who had dental work and was on opiates and constipated because of it. I had her take that, and she thinks I'm a genius. That can be life-changing. Qcynia, it's another one, weight loss and weight maintenance. It's phentermine, which we talked about before. So in this form, phentermine is approved for long-term use. With topiramate, again, a medication not approved for weight loss, but we do use off-label. We combine those two, we get more weight loss. Both of them cause weight loss. Topiramate's a medication we most commonly use for seizure or migraine headache. It causes taste changes. It makes carbonated beverages taste flat, terrible, and wrong. I have used it to bust more than one Coca-Cola addiction, including my own. It also seems to interfere kind of gradually, not immediately, with cravings for sweets and starches. Can't use it in pregnancy. Obviously, we don't use any weight loss meds in pregnancy. But the other thing is topiramate can cause cleft lip and palate birth defects. It can also increase your risk of certain types of kidney stones, and we do not use it in people who have glaucoma. Contrave is a combination of naltrexone, which is a medication we more typically use to treat opiate and alcohol addiction, and bupropion, which is Wellbutrin. It's an antidepressant. It's the one that helps people quit smoking. It can cause a little bit of weight loss on its own. We add naltrexone to it, we do get more weight loss. It seems to keep the active molecule of the drug in the part of the brain it needs to work longer. So it works in the appetite regulation and reward center of the brain. Helps you decide if you really want that. Cannot use this medication in seizures because bupropion can lower the threshold for seizures, make it easier to have seizures. Also can't use it in people who take chronic pain medications because the naltrexone will block those receptors and make their pain medication not work, and that would be no fun. Liraglutide. It's Victoza for diabetes and Saxenda for weight loss. This is the same medication made by the same company under two different brand names. It's GLP-1. GLP-1 is one of our full hormones. So this medication looks like our full hormone. It helps us feel full. It also helps with insulin resistance. There's some contraindications there, you know, medullary thyroid cancer, MEN type 2, which those are super duper rare. And this class works really well, probably the most successful weight loss class of medications. Here's its cousin, semaglutide. It's Ozempic for diabetes. It's Wegovy for weight loss. Same medication, same company, two brand names. Again, it helps us feel full. The big issue with these medications, with both of these, is that they're expensive. Over $1,000 a month if insurance doesn't cover them. So for people with diabetes, it's easier for me to get them on the drug because they've got, you know, I can get them in on that version. It's super expensive, and then it's an injection. One of them is once a day, the other one's once a week, but they are really helpful for weight loss. They also help with lipids or cholesterol. They also can improve fatty liver and improve cardiac survival, especially in diabetics. Vyvanse is actually not approved for weight loss. It's approved for binge eating disorder. Also, it's approved for ADHD. It's a stimulant. It's even more potent than phentermine, even more tightly controlled. Gelesis, or Plenity is its brand name, is approved for overweight and obesity. It actually cleared the FDA as a device, so it's kind of cool. It's capsules of cellulose and citric acid, which are plant fibers. You take it with 16 to 20 ounces of water before lunch and before dinner. It turns into a gel, and then the gel expands like 400% in size, and you get full and you stop eating. It's cool, but it's expensive. It's like $100 a month. And you can't use it in people who have had any prior stomach or bowel surgery because of risk of bowel obstruction, and that would include weight loss surgery. Metformin. I love metformin. Jackie's heard this before. Sorry. I love metformin for 3 reasons, probably 4. Reason number one, it helps with insulin resistance. It is the super nanny. So when those muscle cells are acting like toddlers and not listening to insulin, metformin comes in and makes them listen. That being said, if this is insulin resistance, then if this is the super nanny, then liraglutide and semaglutide are military school. Those are the injections. It's carbohydrate truth serum. So one of the most common side effects with metformin is diarrhea. And what I will tell everybody when I start them on it is that this drug is going to block some of the absorption of glucose from your intestines. So if you overeat sugar and processed carbs, it's going to make you pay. That's when you're going to get the diarrhea. If you eat plants and animals, you'll be fine. A lot of my patients use this medication because it helps them make better choices. They don't want to deal with that. The other thing is it's cheap. It's on the $4 list. So if people hate it, it's not a huge financial loss. And it should be a fourth reason. My fourth reason is metformin can be used to offset weight gain from medications that cause weight gain. So prednisone, tamoxifen. There's a lot of antidepressant, antipsychotic medications that cause weight gain. Those medications can be life-saving. We can't take people off of them all the time. And so in that case, I can add some metformin and keep those medications from causing them to gain weight. This is a look at comparing multiple studies at how much weight was maintained and how much weight was achieved kind of longer term. And so again, 5 to 10% weight loss, clinically significant, and it's comparing behavioral programs like Weight Watchers and intensive behavioral therapy, weight loss surgery. And I don't know that they separated out which kind. Liraglutide, which at that dose is Saxenda, that's the one for weight loss. Semaglutide at that dose is Wegovy. And then you've got the Qsymia and Contrave. And so you can see that medications are making great strides. And this is just what's out there so far. We have some medications in phase 3 clinical trials that are even better than Wegovy. So in summary, weight loss is hard, weight maintenance is harder, and science can help. The deck is truly stacked against us. We are designed to survive scarcity. There's not a whole lot of scarcity around. If it does come around again, we're gonna make it. That's the good news. The skinny people, sorry, Jackie, you're out. Failure of willpower is not the issue. So many of my patients are physicians and attorneys and CEOs and nurses and high accomplishing people. How do they have willpower there and not here? Like, I reject that. That's not the issue. There's clearly way more things at play. And finally, you probably need to lose less weight to improve your health than you think. And this is me. So it is personal. Any questions?
Well, I just want to say, I came to see in August and I lost 7 pounds, which are all that you're doing. So I just, if anyone's getting Dr. Kelley, she's very good.
Thank you. Yes, I think there's a bit of a wait, but yes, we are taking new patients. And I think insurance has been pretty decent with covering.
I had a bill. The line was complete. Like when I walked in, the receptionist said we had been collecting $300 when it came in, but she said insurance was happening. Totally. So I went in last week with nutritionists and dietitians, and so that was helpful as well. I'm huge on track with it.
Looking on that app to see which office. Is it under Meritas under Total Weight Loss Center? It's on the website.
Once we get done, take it registered.
The only question I see online is they're just asking about reporting, so I'll make sure we record this is recorded, we'll send it out. If you guys would like a copy of it, I can also send it to you all as well, and send it to everybody registered.
Or probably the news function.
Yeah, because you can go back and look at it and refresh if you have questions, you'll be able to can feel what we need in that.
Okay. If you have
And
questions.
the medications you displayed, do any of them have bad side effects with it again?
Any medication can have side effects.
Okay.
Yeah.
Yeah.
And so, at deployment, I go into people in more detail. Like here, I'm just kind of hitting the highlights. But yeah, any medication can have side effects for sure.
So I would want that wouldn't want any medication, but just to do it, change my willpower, have to be accountable for the department on driving towards taking care of what I need to weight loss to improve my health. Because I have 23 grandchildren and I want to be able to get on the floor and play with them. Yeah. Teach them how to play this golf, definitely big. I've had a couple of injuries with my knee because of my weight, so I really want to get all this weight off. So it's also good once to play this golf more. Yeah. Every day if I could. So that was on my plan. Was to come and see you guys. It's my long-term goal.
All right. Okay. All right. Well, we'll see you tomorrow then.
I brought a couple flyers that kind of outline the options for medical weight loss. And I think the great thing that Dr. Kelley set up with our clinic is it's really hitting all those different pillars of the medicine side of it. We have the dietitians on staff and we have the psychologists on staff as well to go over the behavior modification. So it's a pretty cool program.
I'm very thankful because I know you're thankful that you have her on board.
Yeah, we're excited to have her.
Surgical, and that's what I was afraid of doing those surgical parts. Just not for me. It might be better for others, but for me, I kind of nervous about it.
Surgery is still the most effective tool in the toolbox. I have nothing bad to say about it, but if it's not for you, it's not for you. So yeah, we've got it all.
I think we have a team set up to kind of meet you where you are in your journey, whether that be the medical side, dietitian side, or surgical side. We have all components at the clinic as a comprehensive.
Yeah.
And I think make sure to come back to the next week's classes because we will have dietitians talking about the low carbohydrate stuff that Dr. Kelley mentioned, going over that in detail. Our psychologist, Dr. Harris, will be here for behavior modification, and then dietitian coming back again because she loves us so much, and just to kind of really hit home on like the meal planning and kind of round up the behavior part of it. So a really good class set up for the public, so please make sure to come back to those and to continue the education part of it.
Will there be any presentations on various types of exercise? I saw what you put up there. You talked about the diet side of it, you talked about the psychology side of it, you talked about the medical side. What about the exercise?
Yeah, so that'll be in week number 4. And Becky is one of our dietitians, but she is also a certified personal trainer. So in that part of it, she'll go over different exercises and recommendations and whatnot that she can do. Yep. So you got to stick around the whole week. That's how we keep you coming back just a little bit.
Today's the 7th and the 14th, the 21st, and the
Correct. So that's the last one.
okay.
Yeah, I think it switched from a Thursday to a Tuesday just due to room availability here at the